Okay, thanks. So last session, Matt told us how 85% of behavioral health care treatment happens in primary care, and that primary care is the de facto mental health system. So I'm going to talk about how to recognize mental health disorders in primary care. Next slide, please. So behavioral health disorders are very common in primary care. About 50% of primary care patients have an active behavioral health disorder. If you can see, looking at the examples of depression and substance use disorder, how the population health prevalence is, those stats are greatly increased as you go into primary care population. So for example, depression, there's a 6 to 7% rate of current depression in the population. But if you look at patients showing up in primary care, those numbers are more than double, to 15 to 20%. And as the amount of chronic illness comorbidity goes up, the rate of behavioral health problems also goes up. So 24 to 40% of patients with chronic illness have a behavioral health disorder. And it's as high as 40 to 65% after a myocardial infarction or heart attack. For active substance use disorder, including alcohol, it's 10% in the population, 15% in the primary care population. Next slide. So not only are patients with medical issues more likely to have behavioral health issues, but behavioral health issues often worsen the outcome of chronic disease. So we see the kind of the potential for a vicious cycle here. Chronic disease and illness create disability, pain, discomfort, fatigue, insomnia, stress, financial strain, and also medical side effects. And all of these things can add to the likelihood of depression, anxiety, substance use. And likewise, behavioral health disorders interfere with adherence with medications and appointments, lower self-care, increase risky behavior. So in terms of behavioral risk factors, smoking, drinking, eating healthy, exercising. There's a recent article in JGIM, Journal of Medicine Journal, about behavioral health disorders decreasing perceived health competence and the patients that, confidence in taking care of themselves. There's some biological issues. And then, of course, the toxicity of substances. Alcohol causes liver disease, neuropathy, other problems. And you can get infections from injection drug use causing HIV, hepatitis C, endocarditis, and so on. So these are tightly linked to each other. Next slide. So behavioral health disorders are under-recognized. It's been shown that primary care clinicians only identify about 30% of depressed patients, and we probably do even worse with other diagnoses. But this isn't really isn't our fault because psychiatric disorders usually present with somatic symptoms. So people don't come in saying I'm depressed or I'm anxious.
No audio.
Uh-oh. Can you hear us?
I'm getting thumbs up. So if you can't hear us, make sure that your volume is turned up on your computer, or if you're on the phone that you have the volume turned up.
So psychiatric disorders usually don't come in a straightforward way saying I'm depressed, but usually present with somatic symptoms like headaches or abdominal discomfort. This is a process called somatization, the tendency to experience and communicate psychosocial distress in the form of somatic symptoms and to seek medical help for them. And there's a couple drivers of this likelihood of presenting with physical symptoms as opposed to straightforward emotional symptoms. One is alexithymia, the inability to communicate emotion, to recognize and communicate it. But a big one is stigma. It's okay to come in with a headache, but it's less okay often in the patient's mind to come in saying I'm depressed or anxious, even if they know that's what's going on. And when we think of somatization, there's 3 levels to it, and often 2 or 3 of these are operating at any given time. Anxiety and depression can cause autonomic or fight or flight symptoms. Adrenaline and so on can create, say, tachycardia, fast heartbeats, palpitations, increased cramping of the abdomen. Stage 4 sleep deprivation causes everything to hurt more. This is a big part of fibromyalgia. So behavioral health disorders create physical symptoms. And whether there's these symptoms or other symptoms or normal body sensations, these symptoms can get amplified in the way that the patient interprets the symptoms. And so anxious patients and sometimes depressed patients can catastrophize many things, including what could be potentially benign physical symptoms and aches and pains get amplified. And then the other level of that is how the behavioral health condition affects the threshold for coming into the clinic for help with the particular problem. Next slide. So these are some red flags that should make clinicians think that psychosocial issues need to be explored, whether it's a psychiatric diagnosis, substance use, and also social determinants of health. It could be a stressor, financial stressor, homelessness, etc. It's not always necessarily a psychiatric problem. So stress in general. So multiple, vague, inconsistent, or bizarre symptoms. So we call medically unexplained symptoms, a bodily preoccupation, fear and conviction of disease, symbolic meaning or temporal connection.
Still no audio for me.
Press ahead. You know, or if all the symptoms started after a traumatic event or a loss. Multiple caregivers, the doctor, shoppers, treatments or surgeries without benefit. In general, not responding to therapies as expected, and poor adherence or poor self-care. So these are all red flags that should make you think of something else going on. Next slide. So in terms of a diagnostic approach to medically unexplained symptoms, it's important to take a full history and show that you're taking something seriously. And this can be a bit of a tightrope walk between, in terms of ordering tests and follow-up, between being thorough and not missing, you know, it's not medically
Chat, but it won't let me save.
It's not medically unexplained symptoms unless you've ruled out potential medical causes of these symptoms. But on the other hand, if you try to chase down every unlikely possibility, there's the potential of doing a lot of iatrogenic harm with the side effects of tests and procedures and the sequelae of those. So when things aren't making sense, a few questions I've found helpful are to ask the patients, what do you think is going on? Or what do you fear is going on? And sometimes you get a surprising answer. Or why do you come in today for these 3 years of symptoms? What's different? What were you hoping we could do for you? And then often because of the stigma and resistance, sometimes you need to be a little delicate in exploring psychosocial causes of these physical symptoms. So checking for review of symptoms, looking for vegetative signs of depression or panic, you know, trouble with sleep, energy, appetite, concentration, the Siggy caps, or typical symptoms of panic, palpitations, shortness of breath, and so on. The social history, it's important to ask about new stresses and social determinants of health. And stress is often is a less stigmatized way to approach these things. Everybody is happy to say how much stress they're under, but is often less comfortable saying I'm anxious or I'm depressed. And then you can inquire directly about mood, anxiety, and anhedonia, or the loss of drive or ability to enjoy things. And again, as we described, a thorough physical exam, which doesn't cause harm, but trying to be thorough with the studies, but also limit them to not overdo it. And the importance of not having premature closure with medically unexplained symptoms, always keeping in the back of your mind that that there still might be disease going on. But the good news is when you detect and treat a behavioral health disorder, often these symptoms get better, and that's reassuring. But if they're not getting better, you still need to think. I often say to the residents I work with, these mysterious symptoms, they often go away or they get worse and more obvious what's going on. So looking at things over time. So the process of somatization is very common. Basically everybody does it at some point. And there's sort of three buckets you can put people in your assessment. One, which is very common, is that there's no psychiatric disorder, but it's basically an acute stress or worried well, or often it's a scenario like a relative or friend just had a heart attack and people come in with these very atypical chest pains. That's where the question, what do you fear is going on, or what do you think is going on, can be helpful, because I might not think, this doesn't fit at all with a heart attack, but the patient's thinking that in their mind. So these folks respond to reassurance. Then the next bucket, which is also quite common, is that the patient acknowledges a psychiatric issue. And I often use the mind-body interaction as a more, or as a less stigmatized way to bring this up. And people recognize that, yes, stress, anxiety, depression is, I agree, that's a problem here, and we can go ahead and treat or refer for that. And then the challenging group of patients, which is probably in the 5 to 10% range, is those who don't accept who have ongoing symptoms, can't be reassured, and are unaccepting of a psychiatric diagnosis that we have a sense as clinicians is what's going on. They may have somatic symptom disorder and can be challenging patients, and that would be a whole nother talk to describe how to handle those folks. And then because we're not so good at detecting behavioral health issues, and because it's so important to do so for the patient's overall health and well-being, screening is recommended. The U.S. Preventive Services Task Force recommends screening for depression, unhealthy alcohol use, and as of last week, illicit drug use. This is still a draft statement, but is certainly going to go forward to be accepted. There's a little, there's no professional organizations recommending screening for anxiety, but it's probably a good idea. And at a minimum, there should be case finding, meaning if there's been one of these red flags, that it's important to explore anxiety, and using these screening instruments can be helpful. We don't have time today to go into all the different screening instruments, especially for alcohol and substance use, but the PHQ and the GAD 2 and 9 and 7 for follow-up are pretty much the way to go for depression and anxiety. So in summary, think about whether the patient has a behavioral health disorder when there isn't a clear cause for the symptoms, there are adherence or self-care issues, or a patient has a significant burden of chronic disease or severe symptoms. And screen all patients for depression, unhealthy alcohol use, illicit drug use, and probably anxiety at least yearly.